It's my pleasure to introduce Meryl Simon, who will be giving grand rounds this morning. For those of you who don't know her well, which is probably actually not too many of you because she's been here a while, Meryl originally hails from Merrick, New York. It's on Nassau County in Long Island, famous for Ben & Jerry of Ben & Jerry's, and Lindsay Lohan, who actually went to high school with Meryl. Not friends as far as I understand. And then went to Muhlenberg for college in Philadelphia, Drexel for medical school, and then came here for integrated residency. She will be heading to Texas. Just got notice this morning that she got her order, so it is official. She'll be moving to Temple, Texas, where she'll be stationed as an active duty Air Force. And she'll be speaking to us this morning about Vascular Lab. So, Dr. Simon.
So thank you for that wonderful introduction. As you just heard, my name is Meryl Simon. I'm one of the graduating vascular surgery chief residents. And today my presentation is on everything you ever wanted to know about the Vascular Lab. So in usual military fashion, these are the views of myself and do not represent those of the Air Force or the Department of Defense. And although I have no financial disclosures, I tend to talk very fast, so I apologize in advance. And when I'm nervous, I tend to talk even faster. So I will try my best. So when I was planning this talk, I didn't really know what I wanted to talk about. So the advice I was given from many people was talk about what you know. Well, I'll admit I watch a lot of TV, but I didn't think recapping the greatest TV series from 2013 through 2019 seemed appropriate, although probably would be a lot of fun. And I also love to talk about my kickboxing days, and I would love to talk about the current MMA industry, but I couldn't quite tie that into vascular surgery. So I settled on this, everything you ever want to know about the Vascular Lab, or what I think is a more appropriate title, but probably wouldn't fit on the emailed slide, everything you've ever wanted to know but didn't realize you wanted to know about the Vascular Lab. Okay, so what we'll talk about is what is the Vascular Lab. We'll talk a lot about specifically the UC Davis Vascular Lab and the history of the UC Davis Lab. We'll talk a little bit about the history of the Vascular Lab, and then finally we'll spend about the second half of the time talking about some common lab studies that I think everyone should know a little something about. Okay, things I will not cover, the Doppler Equation. I'm promising right now that I will make no reference to the Doppler Equation after this slide. And on that, I will not talk about any physics at all. I'm sorry if you were hoping I was going to. It's just not going to happen. We also won't have time to talk about the specifics of vascular lab interpretation or management, but happy to do that after. Okay, so what is the vascular lab? Well, it's not this type of lab, despite some of you might think. The vascular lab is a place where we perform non-invasive imaging really from head to toe using duplex ultrasound. And it's useful for both not only diagnosis, but also management and surveillance and follow-up. Here we have an accredited lab with trained sonographers that go through a pretty intensive schooling to get where they are, and we'll go through a little bit about that. So I wanted to start off by talking about our lab here at UC Davis. We have an extensive lab that includes inpatient and outpatient services. The inpatient lab, if you guys don't know where it is, it recently moved, but it's near radiology in the pavilion on the first floor. It's actually open 7 days a week from 7 a.m. to 5 p.m. And they have a physical lab, but they also often go portable. They'll go to places like the ICU and the units to perform studies. The lab is unique in that they do their own triaging, so they'll look through the EMR charts before doing a study, and they'll decide how to prioritize studies throughout the day. They'll also do things not exactly asked of. If they find other abnormal findings, they'll kind of go out of their way to further investigate those things. And then they'll also look at previous imaging studies for comparison and often make notes of those things in their report. One other thing to mention is in terms of the inpatient lab, 75% of studies are ordered by non-vascular surgeons. So most of the inpatient studies are ordered outside of our specific department. The outpatient lab is located across the street in the ACC in the basement. This is open Monday through Friday from 7 a.m. to 5 p.m., and this is more of an employment type basis. We have 11 current technologists here, and they range from anywhere to 5 to 19 years of experience with UC Davis. So on average, the lab does 30 to 35 studies a day. About 10 to 15 of those occur on the weekends. 850 studies a month. And last year, the lab performed over 10,000 studies. So they're pretty busy. That might not mean something to some of you, but talking about other labs where maybe they have one tech and they're only performing 5 to 6 studies a day, it's quite a busy lab. So we have 74 different billable exam codes that you can order through the EMR. And if you've not ordered a study before, all you have to do is type in VL and the whole list of options will come down. This is different than general radial ultrasound studies where you would start with US to order one of their studies. I'm now going to go through each study individually and talk about it in immense detail. Just kidding. But you can see we have quite a variety of things really from head to toe that are available for our patients. So what are the studies a little bit like? Well, they take anywhere from 60 to 120 minutes. They're actually quite extensive. Things that are 2-hour blocks are things like bilateral lower extremity arterial and graft studies. Dialysis access takes a little bit, and so do aortic endografts. And then something that takes quite a while that you might not think is reflux studies. And then they actually do fibular flap evaluations for plastic surgery, and those can be quite time sensitive. The amount of time taken for the lab is not only when the patient's on the table, but also the technologist generates a report. They'll usually do hand-drawn images of their findings, so that takes quite a bit of time as well. So some other helpful hints and tips about the lab is that they'll often come and help us intraoperatively in the operating room. If you've worked with our vascular surgery service, you've probably seen this. They'll come in at the end of bypasses to help us evaluate the inflow, the outflow, the venous conduit if there is one, as well as carotid endarterectomies. They'll come and help us take a look after and make sure the patch and the endarterectomy plane looks okay. And I'll show some examples of that after. They have also been known occasionally to go in for other services, trauma, to look at dialysis access, plastic surgery, to look at plaque perforators. One thing that the lab wanted you guys to know is although they don't do walk-ins outpatient, you can do urgent add-ons, and they're always willing to help you get patients seen if you have an outpatient. You just need to call the radiology scheduling, and they're pretty good about getting people in same day. And then something we are asked frequently is, what about after-hours studies? Well, that's usually, unfortunately, not an option. We don't have people here overnight, but general radiology will do DVT studies, but it's really specific to lower extremity and in the emergency room. Okay. Does anyone know who reads our vascular lab studies here? Yeah. So radiologists, cardiologists, internal medicine, vascular surgeons, actually all of these people can read vascular lab studies. Here specifically we do, but really anyone with a special license called an RPVI, which I'll talk about, can read a vascular lab. So our lab also participates in CQI. It's a very academic lab that we have here. So quarterly, we all sit down, the vascular lab staff and the Division of Vascular Surgery, and we go through cases, we look at images, we discuss the patients, and we'll also compare it to angiographic and operative findings. So we really do a lot to try to constantly improve the lab. So the next thing I wanted to just mention a little bit about was accreditation and credentialing. This is really important because a lot goes into, number one, obtaining your own personal licensure to read and interpret vascular labs, but number two, in becoming an accredited lab. Because it's recognized that you really need a specific body of knowledge and training and expertise to perform and interpret these studies. So what is credentialing? Well, credentialing briefly is verifying professional knowledge and qualifications, and it includes both certification and licensure. And then accreditation is just credentialing, but on a program or facility level. We'll talk a few about these things. These are the organizations that were developed for credentialing and accreditation for the vascular lab. So this slide's a little boring, I apologize, but Intalos is a parent company. They're a global non-for-profit organization, and they created 2 companies below them called the ARDMS, which is important to us because it credentials our vascular technologists, but it also credentials all technologists that work with ultrasound. And then APCA, which is the Alliance for Physician Certification and Advancement, is the people that license and credential us, the physicians that interpret the vascular labs. But again, they have certifications for all sorts of medical imaging. So RVT, what is an RVT? It stands for Registered Vascular Technologist. And to become a registered vascular technologist, looking at the wrong screen on mine. You have to take something called the Registered Vascular Technologist exam, and it includes both a physics of ultrasound portion and a vascular specific knowledge. And there's prerequisites. So our techs usually go through a 4-year Bachelor of Science degree program, and their 4th year is usually spent in a clinical hands-on setting. And actually here at UC Davis, we're a site for the Oregon Institute of Technology. So they will come and spend their 4th year here working hands-on with our techs, learning how to do vascular ultrasound. And then just like any other certification, there's a regular CME that's required. So how can you obtain an RPVI? Well, if you've ever thought, oh, I want to learn how to read vascular labs, here's how. So there's a test. To sit for that test, you have to have a physician's license, but you don't have to be a vascular surgeon. Like I mentioned, you can be any type of physician, and it just requires some formal and informal training. It requires about a log of 500 reports that you've read and interpreted of ultrasound. And then the test is usually about 4 hours, 185 questions, and really goes over everything from vascular anatomy to general ultrasound to reading and interpreting vascular lab studies. And then, of course, like anything else, there's certification in CME. I have to write them a check for $175 every year to maintain my certification. Something interesting that happened a few years ago is this is now a mandatory part of vascular surgery training. So before sitting for your oral boards, you do have to obtain your RPVI. And then I just wanted to show this because the RPVI has actually not been out very long. The pilot exam was in 2005 where 50 physicians took it. Before that, people that were really interested in the vascular lab would actually obtain their RVT and become a vascular technologist. And then when this exam came out, that's really moved where people are taking their RPVI. And you can see how that has really increased as it's now become a mandatory part of training. And then lastly, the IAC is the Intersocietal Accreditation Committee. These are the people that accredit the labs. In 1990, it was realized that we need to set standards for labs. Every lab really should be doing the same thing and providing the same services. So not only vascular surgeons, but cardiologists, radiologists, neurologists, and vascular techs got together, created this organization, and they review the standards every 3 years, and programs have to go through a reaccreditation process every 3 years. There was 15 labs that started the program in 1991, and now there's only over 2,600 labs that are currently accredited. 50% of labs are run by a vascular surgeon, but the other 50% are run by radiologists or cardiologists. And then people say, well, why should you have an accredited lab? Well, these days, insurance are often not paying for studies that are done at not accredited labs. Okay, so moving on to some stuff a little bit more interesting. So some history of the UC Davis Vascular Lab. So the lab was started here in the late 1980s by a Dr. Michael Conti, who actually doesn't work here anymore, but he does work in the local Sacramento area. And then a few nurses, Cheryl, Debbie, and Francine. And it was really an all RN-run department. This was before they had RVT degrees. And the first vascular trained technologist arrived here in 1993. The Sacramento lab here was the first accredited lab in this area, and that was in 1994. This is Kevin Lindholm. He was the first student to come as part of the OIT program in 1995, and he actually still works here at UC Davis in the radiology department. And Dr. Pevic came here in 1992, and he immediately had a special interest in the lab. He ended up becoming the medical director in 1995 and really helped increase not only the volume of the lab, but what they do, moving both inpatient and outpatient services. And then when Dr. David Dawson joined in 2002, he was really instrumental in bringing the lab into academics. They now participate regularly in the Society for Vascular Ultrasound meetings and do a lot of research here. So something else I found interesting when learning about the lab is from 1993 to 2007, the lab, both the technologists and physicians, would participate in these free annual screenings that they would offer to retirement communities and Native American centers. And this was completely on their own time on the weekends when they weren't working. They would offer things like carotid screens, AAA screening, ABIs, and then physicians would be there to even counsel patients. At the end of the day, they'd be able to give a preliminary worksheet to the patient to then bring to their primary care doctor to get further referral and workup. They'd really crank out a lot of studies, often over 100 studies in about a 5-hour period. Up here on the left upper hand side of the screen, you can see Dr. Pevic and Dr. Laird counseling patients. Unfortunately, in 2007, the program was stopped. It's a little unclear why, but I think it had to do with some medical legal reasons. So some fun facts about the lab. Nobody has any idea why, but for several years, billing from the vascular lab all went to the pediatrics department. And we still can't figure that out. Occasionally, one of the nurses, Cheryl Fisher, would actually go to patients' homes and perform studies if they were too incumbent to come into the lab. And then initially, everything was signed on paper. Well, you might say, well, why is that interesting? This was before the days of EMR. Everything was on paper. Well, if you have vascular lab studies that you have to read and interpret and you can't see the images, you're going blindly off what the tech's telling you, and you're hoping that you have good techs like we do here that you can trust. But if any of you know Dr. Pevic, you know that that would not sit well with him no matter how good your techs are. So what he ended up having them doing was putting all the duplex scans on VCRs, because you couldn't archive anything in those days. You then got a cart with a bunch of VCRs at the end of your day in your office that you then had to review and read. But luckily now we have everything on Epic. Something else that was interesting was that the first machines, as you can picture, were really bulky and heavy, and to move them around the hospitals, these nurses could not push them, so they actually would attach motors to move them around the hospital. And then this machine over here is the ATL 1000, and Dr. Pevic was so excited in like the mid-1990s, him and a bunch of techs from the Vascular Lab went to Seattle to go see this machine because this was a new machine they'd be purchasing. And I looked it up on eBay, and you could get this for like $500 now. But obviously our labs are a lot more modern. Okay, so a little bit about history about the Vascular Lab, and specifically I wanted to talk about this man, Dr. Eugene Stratis. Some of you may know him, many of you may not, but he's actually who most people consider to be the father of the Vascular Lab. And I don't know if you know, but many of us here in this room are related to him. So Dr. Dawson was one of Dr. Stratis' fellows and trained under him. And as you know, most of you in this room have probably learned something from Dr. Dawson throughout your time here. So Dr. Stratis was born in 1928 in North Dakota, but then moved to Washington, where he did most of his training throughout medical school residency and eventually joined faculty there at the University of Washington in 1994. And his professional life really spanned the development of the Vascular Lab. He was really the one that spearheaded using the first indirect physiologic techniques to evaluate vascular disease all the way through the modern duplex scanner. He wrote countless clinical trials, and studies and papers on the application of using duplex in vascular surgery. And a quick PubMed search alone will bring up over 300 results of papers that he wrote really on the development of the Vascular Lab. And most of his protocols that he created at the University of Washington are still widely used today. He also literally wrote the book on duplex scanning entitled Duplex Scanning in Vascular Disorders. He wrote the first edition in 1990, and when he died in 2002, he had just finished the third edition. Fortunately, his memory does live on, as Dr. Zieler, who works at the University of Washington, and Dr. Dawson have continued to write his books. But a lot of people at our institution have been contributors of his chapters, including both Vascular Lab staff and vascular surgery residents and fellows and current attendings. So on a final note about Dr. Stratis, I did want to read a few quotes that I found fascinating from his SVS presidential address in 1990. He stated, "I wanted to work in the gastrointestinal research lab, but there was no room. I was told I had been assigned to work in an area of vascular disease, a subject about which I knew nothing and had no interest. Since I knew nothing, I was forced to start from scratch. I was horrified to find that the only tools available to me were my fingers, ears, eyes, and arteriography. I decided to turn to our physiologists who spent their lives measuring things to see if they could help." And that was really where the Vascular Lab took off from. Okay. So for the rest of the time, I thought it'd be important to talk about some common lab studies that I really think everyone outside of vascular surgery should know a little something about. So we'll start with the carotid duplex. The complete carotid study looks at the internal and external and common carotid arteries, as well as the subclavian and vertebral arteries bilaterally. Blood pressures are taken. And the study usually takes anywhere from 20 to 90 minutes, depending on the simplicity or complexity. It's scheduled for about an hour. The vessels in the neck are pretty shallow, so usually a 7.5 to 12 megahertz probe is used. And it's a pretty safe, effective, and accurate test. So the duplex is read based on velocity criteria, and we actually use the University of Washington criteria. But just know that if you do go to other hospitals or you work at other hospitals in the future, they might use a slightly different criteria. So you might see something else in the read if you order a carotid duplex scan. So what are you going to see if you order this study on this patient? Well, you'll see either no significant stenosis or less than 50%, 50 to 79%, or greater than 80%, or potentially an occluded artery. And the only reason I bring this up is because this is really important in how we manage these patients, which I'm not going to go into today, but always happy to talk about later. So who should undergo a carotid duplex? Well, when you're talking about an asymptomatic patient that you want to screen, their high-risk factors are going to be patients with symptomatic carotid disease, and then diabetes, hypertension, smokers. But two groups I wanted to specifically mention were patients with a history of neck or head or neck cancer and irradiation, because that does apply to a bunch of people in this group that you might take care of these patients. And there's good data that shows that these patients should have a study 10 years after their irradiation, because they can have upwards of about 30% incidence of carotid-related radiation arteritis. Most things will quote closer to probably about 10 to 20% though. And then the second group I wanted to mention was patients undergoing CABG. And you should consider it in these patients, especially if they're greater than 65, if they have a history of TIA or stroke, or if they have any of the other risk factors noted above. So other things, well, we'll often get carotid duplex studies on people that are symptomatic. So transient ischemic attacks, amaurosis fugax, or stroke. Patients with known disease, will follow them over time for progression. And then we'll do intraoperative studies, as we mentioned earlier. And then follow up after we've revascularized them with endarterectomy or stenting. And then cervical bruit, this is something that'll occasionally come up in the request for obtaining a vascular study. And if you have a patient with a cervical bruit with no other risk factors, you don't need to get a carotid duplex on them. There's good data that shows that these patients often will not have significant stenosis. But if they have a cervical bruit with the other risk factors, then you can go ahead and get it. And just to really drive that point home, we have lots of patients that have very high-grade stenosis that actually have no bruit. So I wanted to show an example of an intraoperative completion study. On the left of the screen, you see a B-mode image, and you see plaque disruption of the common carotid artery. And then on the right of the screen, you see the high-grade velocity elevation through that. And occasionally, this will lead us to revise our patch or our endarterectomy plan. So I think that intraoperative duplex studies are very important, and I think we're really lucky here that we have techs that are readily available to come into the operating room and help us. Here's some other pretty pictures. So these are other interesting things that you can find on carotid duplex, not just stenosis. So they're good for following aneurysms, dissections. You can identify even fibromuscular dysplasia based on things that are suggested by the waveforms. And then other things like non-vascular pathology on the right side of this picture. Let's see if I can make this work. You see the internal and the external carotid artery have actually been splayed apart, and this is a carotid body tumor here in the middle. And then over on this side, this is the carotid artery here, and this is actually a really large carotid aneurysm. So some other interesting things for all the trauma folks here. Carotid duplex is really good at identifying as well as following over time things that you're going to treat conservatively, such as small pseudoaneurysms that you find in the zone 2. This picture is from the Journal of Vascular Surgery. This is a common carotid artery of a 28-year-old that was bungee jumping. Now, the bungee jump itself was uneventful, but 10 minutes after, he complained of worsening neck pain and actually had stroke-like symptoms and was found to have a dissection of his common carotid artery. And then on the right of the screen, this is actually a normal internal carotid artery, but it's a pretty picture because it's tortuous. And a lot of patients have tortuous carotid arteries, and you'll be fooled into thinking that maybe they have an aneurysm or something abnormal in the neck. So I also wanted to mention inappropriate indications for a carotid study, because I think this is important. There's a lot of data that shows that duplex studies for inappropriate indications, and these include isolated syncope, dizziness, tinnitus, and vertigo, actually have very low rates of significant stenosis. And actually, most studies will quote 0% incidence of significant stenosis in these patients when this is the indication alone. And the only reason I bring this up is because this is something that does come up pretty frequently on our indications for studies. And although the carotid duplex doesn't really have a patient risk, it's a non-invasive study, it is time-consuming, and it does require a strain on the vascular lab and on the healthcare system in whole. So next time, just consider that. Okay. So the next study I wanted to talk about was the DVT study. This is easily the most commonly ordered study in our vascular lab and probably across all vascular labs. But before we had duplex, ascending venography was actually the gold standard for identifying and diagnosing DVT. But aside from its invasive nature, it comes with a whole host of issues. It requires that you have a cath lab. It requires you have expertise to do the study. And then what I find most interesting is just performing the study itself can lead to thrombosis, which isn't really ideal when that's the diagnosis you're looking for. So fortunately, in about the mid-1980s, the duplex came out and is now the gold standard for diagnosis and surveillance of DVT. So again, it's the #1 test performed by most vascular labs. They really evaluate from the calf to the groin. Usually a 5 to 10 megahertz probe is used, but sometimes they need something like a 3 to 5 when they're looking in either more obese patients or at the deeper veins, like the iliac veins or the IVC. And they'll look at the veins in both B mode, looking for compression or coaptation of that vein, as well as looking for intraluminal echoes. And also on duplex, they're looking for normal venous flow. And normal venous flow means it's continuous and it's phasic, so it adjusts with respiratory variation. So if you've not seen a normal study before, here this is a B mode, this is the non-compressed vein, and that's compressed. And then here is just the normal respiratory cycle of the vein. So another point I wanted to mention was augmentation. So this is something that's done on all our DVT studies. And what is augmentation? Well, it's the sharp upstroke of antegrade flow that's in response to the distal limb being compressed. And it suggests patency between where you're compressing and where the duplex is. So you'll see a few different things when you're looking at these waveforms. You'll see the normal phasic flow, but then you'll see the augment. And that's suggesting that those veins in the intervening segment are all patent. Another special point I wanted to mention is when you're requesting studies, if you do want to specifically have the technologist look at the iliac veins or the IVC, you should go ahead and make them NPO, usually for about 4 to 6 hours, as those are deep veins and they have a lot of overlying abdominal structures. Additionally, the standard DVT study can suggest a more proximal venous abnormality by showing lack of common femoral phasicity or venous flow. And often our technologists are pretty good, and they'll not only look at the contralateral common femoral vein, but they'll even go higher up and try to look at the iliacs to figure out what's going on with your patient. And just 2 examples I wanted to show here. This is looking at the duplex through an external iliac vein, and although it's patent with continuous flow, it lacks the respiratory phasicity. So if you see this, it suggests a problem either in the common iliac vein or the IVC. This particular patient had a pelvic mass that was compressing their common iliac vein, leading to right lower extremity edema. And then just to drive that point a little bit more, this is the same thing, but this is a patient with a known common iliac venous occlusion. So why do we order a study for a DVT? Well, patients with symptoms is the most common reason, lower extremity pain or swelling. Often patients with a recently or newly diagnosed PE, they'll obtain a study to look for potentially a source of DVT. And then across the board, out of all the studies that are performed, only about 10 to 20% are actually positive for DVT. So some other pathology that can be found when you obtain a DVT study, you can see a whole host of things. You could have Baker cysts, hematomas, aneurysms, and every once in a while, we'll even have a study ordered for leg pain, and the tech will tell us, hey, all the veins looked great, but by the way, that popliteal artery is occluded, and they'll end up having a diagnosis of acute limb ischemia. So another question that arises is, should you order a bilateral or a unilateral study? And there's been a lot of research that has gone into this, and really the consensus is if you have an inpatient that you suspect has a DVT, just go ahead and order a bilateral study, because about 34% of inpatients who have a DVT have a silent contralateral DVT. This is also similar to patients with active cancer. They have about a 38% incidence of having a silent contralateral DVT. But if you have an outpatient that has unilateral symptoms, does not have cancer, has not had prior DVTs, really no other symptoms to suggest a systemic disease, you're pretty safe with ordering the unilateral study. And this is just a figure from one of Stratis's books to really just see that point. New patient, inpatient, just get the bilateral study. Same if you have outpatient or emergency room with any evidence of PE or systemic symptoms, also get a bilateral study. But if they're outpatient or emergency room and they have just unilateral symptoms, you can be safe to order a unilateral study. And the last thing I wanted to mention about DVT was the caffeine DVT, specifically the isolated caffeine DVT. And although I promise not to talk about management, this is one area I'll bring up because we do get a lot of questions about this. So the data actually supports not beginning anticoagulation for isolated caffeine DVTs. And this is from the 2016 chest guidelines, which are the most recent chest physician guidelines. And the reason for this is they have a very low incidence of propagation. Only about 15% of caffeine DVTs will propagate to the popliteal vein. And at that point, if you find that, then you can begin anticoagulation. So what do you actually do? Well, the guidelines suggest not anticoagulating, but instead performing a repeat study in about 1 to 2 weeks to look for progression. At that point, most patients will have resolved their caffeine DVTs. And like I said, only about 15% will go on to have them. Patients that you might consider just anticoagulating and not going with this approach would be patients that have really extensive symptoms, extensive thrombosis, active cancer, or history of DVT. And then for everything you ever wanted to know about DVT and VT in particular, I'd refer you to the chest guidelines. So the last thing I wanted to talk about was ABIs and toe pressures. Although not a duplex study, this is a physiologic test. This is something that's also commonly performed in our vascular lab. But shockingly, many of you may not know this, but you can actually perform an ABI yourself. And if you've rotated on the vascular surgery service, I really hope you learned how. All it takes is a blood pressure cuff and a Doppler. So how do you do it? For anyone that doesn't remember and needs a refresher, well, you'll take a cuff, you'll place it around the distal calf just above the ankle, and you'll obtain a Doppler signal from either the DP or the PT. And then you'll inflate to suprasystolic pressures. and you'll slowly deflate, and when the signal returns, that's your ankle pressure. You'll then repeat the same thing for the opposite, either PT or DP, whatever you didn't do the first time, and then you'll take a brachial blood pressure. The equation is pretty simple. You just use the higher of the ankle pressure over the higher of the arm pressure, and that's your ABI. Something I like to do with the medical students when I'm teaching them about an ABI is I ask them why they use the higher of the arm pressures and not just use the ones on the same side, because a lot of them will tell me like, oh, use the right side for the right side. But you actually don't have two aortas. It's all one systemic blood pressure. So you're trying to get to the true blood pressure. So what are the benefits of doing an ABI? Well, besides the fact that you can actually do it yourself and it's pretty easy, it remains relatively constant despite day-to-day variations in blood pressure. So it's really good at using to follow up patients over time as well as assessing perfusion after revascularization. But there are limitations. Patients with upper extremity arterial disease, so if you have stenoses or occlusions of the subclavian, axillary, or brachial arteries, it can lead you to a falsely high ABI. Additionally, tibial calcifications can lead to falsely high ABIs. And this can be suggested if you either can't compress the tibial vessel, so sometimes you'll see NC on the study, non-compressible, or if you have an ABI over 1.3, then that can suggest to you that you have incompressible tibial vessels. And this is actually a great use for the toe pressure because the digital vessels are often pretty resistant to calcification that the tibial vessels undergo in certain patient populations, such as those with diabetes or end-stage renal disease. And that can give you a pretty good assessment of the blood flow to the leg. The last thing I wanted to briefly mention was the exercise ABI. This is something we do have available in our outpatient lab that we're pretty fortunate because not all labs have this. And I won't go into the specific details of it, but this is really good if you have a patient that comes in, has classic symptoms of arterial claudication, but has palpable pulses and a normal ABI. This is a great way to really see if they have an arterial component to their symptoms. So in closing, I wanted to let everyone know that we're always happy to answer any questions you have, and that includes both the vascular department as well as all the vascular lab staff. We have a bunch of really wonderful, experienced people here, and if you have a question about what's the right test, what's an indication, or what are other options, because there's 74 tests and you only know about the DVT and carotid studies, we have a lot of different things available that we can help you with. And then I have a lot of people to thank with this. Drs. Dawson, Zieler, and Pevick helped me provide information about the history of the vascular lab, as did the nurses Francine and Debbie. And then all of our lab staff, Ed, Dave, Mackenzie, and everybody that works in our vascular lab is really wonderful. And if you ever have time to visit them, they're really great and they're a really great source of knowledge. And then no presentation would be complete without a whole bunch of pictures of my 6 years here. So thank you to everyone that's worked with me here. I've really enjoyed my time here. And then all the friends I've made that have helped me survive these 6 years here. And then last but definitely not least, my family. I have a wonderful husband that really holds things together at home while I spend most of my waking hours here. And then in closing, thank you for your time. I'm happy to take any questions. I would love to do like a mic drop and just walk out. But... So my other grand rounds idea was how to give grand rounds in 5 minutes or less.
I will say, just to start out, I've been here a year, and I think one of the real gems that we have at this stage is the Vascular Lab. It's really, if you ever go and take an actual look at the product that the lab techs put out, it's really tremendous, and you won't find this anywhere else. OICV Organs and Technology is really one of the premier places for training. A lot of our folks here train there. Actually, the Vascular Lab manager at Stanford was an OIT grad. He did his training here too, and so there's that whole pattern. So it's really a great resource, and the staff is actually extremely helpful if you have any questions. Yes, Dr. Rodriguez.
Very nice talk. You commented a little bit about although you said you weren't going to talk too much about management, but you did mention Cath DVTs. And I get these questions all the time as well in terms of upper extremity DVTs. What do you do for those?
So upper extremity DVTs are treated the same way lower extremity DVTs are treated. The guidelines do say you should treat for 3 months. we get a lot of questions more about, not about the upper extremity DVT, but especially about patients who have a DVT with associated catheters and other things like that.
Yes.
I thought it was an excellent review and very nice talk. Just quick points. Just historically, it was Sebastian Conti, not Mike Conti, that started the lab.
I think his first name was, you might be right. I did talk to him though, and he referred to himself as Mike.
He's a personal friend.
Oh, okay.
Second of all, I also want to commend the Vascular Lab here. You're absolutely right. It's certainly one of the best, if not the best, Vascular Lab around the world. Because of its attention to detail and quality control. With respect to caffeine trauma, I certainly agree that maybe only 15% probably. There are studies that are certainly very valid. The problem is, and if you look at, yes, the recommendations by the chest physicians, and of course, if the only thing that they're concerned about is pulmonary embolism, then fine, absolutely, don't study the caffeine trauma, no treatment. But then if you accept the fact that 50% do propagate, when they do propagate, they knock out the function of the propagating valve. It's a very important valve. And the development of untreated valvular stasis can become this ulceration. So if you want to wait when they develop that, and you have nothing to do to prevent that, then fine, let's look at propagating valves. But otherwise, respectively, treat and campaign.
Well, I think that's definitely a valid point. I think it's something that the physician and the patient can discuss then, because obviously there's not, anticoagulation is also not insignificant either. But I think waiting a week and doing a repeat study and seeing if there's been progression is a really good intermediate option as opposed to starting someone on potentially lifelong anticoagulation, because unfortunately we often stay 3 months, and then how many people do we get back where 3 years later we found that they had one DVT and they've never been taken off their anticoagulation.
Yes.
Really nice talk. It strikes me that this technology has been fairly static for the last 20 or more years, just as long as I've been. And everything we read now is AI and all these very, technological advancements. Do you see this, evolving in any time?
So there are some advancements being made in duplex. Specifically, we now have the ability to do contrast enhanced studies. We don't specifically do them here, but there are a lot of places doing that. But I think duplex offers something that a lot of other things can't offer. You can see stenosis on CT, but you can't see the velocity elevations through them. And it's also something that you can do hands-on in the moment when we're trying to assess these.
I will say that part of the challenge